So let's start the journey then with the ECG. As I say, if you read American publications, you may well read it as the EKG, the electrocardiogram. And let's start to get to grips with what the ECG is identifying for us and how we, as an applied practitioner, can make use of the information that the ECG is showing us. So we've got to have a rationale. Now, we kind of set that out in the introduction to this podcast, but it's fundamental to perhaps put some meat on the bones here in terms of really setting out why using an ECG is of fundamental importance to us in both clinical and non-clinical population groups. So to that end, what we understand is that the ECG, as we've got here, provides vital diagnostic information, both for immediate clinical decision making and, more importantly, for identifying patients who develop ECG changes which make them candidates for, say, early invasive coronary investigation. So this really alludes to the clinical population group. This really alludes to the idea that you can actually identify key pathologies and you can track somebody's ECG over time. You can look at threshold values, and actually based upon that you can identify these individuals are probably going to go forward or have to go forward for some form of cardiovascular intervention, so some kind of surgery. So that really sets out the kind of the classic role of the ECG. Coupled with that, it is very, very useful in diagnosing medical conditions. So we know, for example, acute coronary syndrome, but also the fact that you can now monitor this electrical activity of the heart, and the fact that, as you'll see, the electrical activity and the change in the electrical activity is linked to the activation and deactivation of key structures and therefore key responses, means that you can start to understand the dynamic changes in the morphology of the heart. And so you can start to really understand if there have been adaptations or limitations to the heart. In other words, you can stratify risk. And you can stratify risk in terms of acute coronary syndromes. And so you can start to deal with things like what's called ST elevation, myocardial infarction, heart attack. ST elevation, ST are two of the sections on the ECG trace that we're going to look at. Elevation is what it says, so it's an elevated ST response, so there's a change in the electrical activity in that component. Myocardial is the heart, infarction is what it's referring to, is the attack. And so if we monitor the ECG and we see a significantly, profoundly elevated ST component, it's probably an indication that the individual is either at the onset or into a myocardial infarction. So again, really lending itself to the role in a clinical setting. But what about during exercise? Well, during exercise, one of the things we know, coronary blood flow has to increase because you've got high metabolic demands. So you've got metabolic demands that are being placed on the skeletal muscle, but crucially remember that the myocardium itself has to be oxygenated. And the first organ that is oxygenated from any cardiac cycle is the heart itself. So if there happens to be a limitation to coronary blood flow, you're going to see that in the ECG. So in other words, if for whatever reason there is a change in the O2 delivery to the heart, it will be visible. So the reason that we do exercise stress testing, and this is something that will be covered in the podcast, which is the week 11 podcast, which is on CPET, which is cardiopulmonary exercise testing. The reason we take ECGs during those is that when we're trying to build up a holistic picture of the cardiopulmonary health of an individual, understanding how the heart is functioning when it's placed under controlled stress is fundamental. Quite often what happens is that we think about the heart and stress being placed on it, and we think about the myocardial infarction. But the beauty with exercise is you can place the heart under stress under reasonably controlled conditions. This is the classic ECG test, where you do an incremental test, like a VO2 max test, to exhaustion, monitor the ECG, and compare the ECG response to what would be anticipated. and therefore you can start to make a diagnosis. So having these controlled conditions under exercise is really fundamental to being able to understand the way in which the heart is operating. So we have a really solid rationale for using ECG, both in a resting condition and also under exercise conditions, or controlled exercise conditions. So let's think a little bit about what the ECG is showing us. So let's dig inside the heart. And the two panels here are really showing us the same thing in many ways, but what they're depicting for us is this wave of excitation that I was referring to, and the key structures that are engaged as a result of this wave of excitation. So remember that the only way that the heart, in essence, contracts, in other words, the way in which that we get the contraction and relaxation of the heart, is through electrical impulses. And what you can see here is that path of information, and primarily you want to be following initially the blue and the green paths. On the left panel, you can see the structures that are innervated. On the right hand panel, you can see the time frame for these. So you can see that on the right hand panel you can see time frame 0.00 in the top part of the heart, and you can start to see as we descend through the heart the time frame becomes greater. The red lines in the left hand panel refer to the idea of the relaxation of the heart, and so this is showing you that wave of excitation across the heart. And so you can see that both the movement is not just in the vertical axis, it's also horizontal axis. But more importantly, actually, if we're thinking about the structure of the heart, we have to think about the structure of the heart three-dimensionally. So actually, the wave of excitation is not only, if we think about dimensions, it's not only the x and the y axis, it's also in the z axis as well. So it's three-dimensional. So you can see that if you look in the right-hand panel, you've got this time frame 0, and then it starts to spread. So let's say time frame 0.4. You can say time frame 0.4. It's where we've started to engage the AV, so the atrioventricular bundle, the bundle of His. But at the same time, you can also see that we've also got the AV node that's being engaged at the same time frame. So you can see that at the same time frame, 0.04, it's not just that we've got a vertical innervation, we've got a horizontal innervation as well. And then what we're not really showing on here is kind of that three-dimensional aspect, which is the z-axis as well. And then you get the descending wave of excitation across the heart. And again, you can see that time frame 0.17, we're still innervating the AV bundle, the bundle of His, but actually you can also see that the inferior vena cava is also now starting to be, not the inferior vena cava, sorry, the Purkinje fibers are now starting to be innervated as well towards the lower axis of the heart. So you can start to see that it's a multi-dimensional innervation, but you can see how each of these components, the AV bundle, the Purkinje fibers, the left bundle branch, the right bundle branch, how they all lie in relation to the key structures of the heart, the atria and the ventricles. So we can start to now build up, because we're monitoring the electrical activity across the heart, which is where the ECG comes in, because we're monitoring that changing electrical activity, which is indicated by those time frames on the right-hand panel, and the positive and the negative. So positive being obviously the blue and green, and the negative being the red trace. Because we're monitoring those and we know how they relate to these structures, we also know how they relate to those components of the heart, the ventricles and the atria. So now, just through monitoring the electrical activity, we can start to build up a picture of how the heart is being innervated. We can start to see how the right side of the heart is being innervated as opposed to the left side of the heart, or how the ventricles are being innervated as opposed to the atria are being innervated, and so on. So it becomes incredibly powerful as a diagnostic tool for us. So here is a typical stylized ECG trace. This is kind of what you see in the movies as an example. And the reason we have it on this kind of hatched background is because the hatched background is used to dictate rate. So one large square generally refers to 1 second. So a large square generally refers to 1 second. And you can see that the cycle repeats. At this point, it doesn't matter what the cycle refers to, but the cycle repeats. And so you can see that if you take the peak of a number of these traces, that we are talking about a 4-second cycle. Okay, so it's about 4 seconds between each cycle. So in simple terms, because this process is repeating, you can say that there is a heartbeat every 4 seconds. In other words, it's repeating every 4 seconds. So we're starting to see heart rate. Now, clearly, what you can see in the signal is there's an awful lot of other things going on. You can see a number of peaks and troughs within the signal. And these peaks and troughs relate to this electrical activity that we're seeing here and those time responses that we're seeing. So remember that we were talking about the fact that you've got to view the heart in 3 dimensions, and you've got to view the notion of this wave of excitation happening across different areas at the same time. So we gave the example of the AV bundle, a bundle of His at about 0.4, and you could see it's at 0.4 seconds, but you could also see at the same time, as we mentioned, for example, the AV node. So the more factors that are involved is going to dictate to a degree how big that signal is that you're seeing on your electrical trace, on the ECG trace that we see here. So this is a typical stylized response. Now, unfortunately, they never look quite this clean. They can look pretty clean in a very healthy population group, but they never look quite this clean. So what we're going to do now is start to understand what the trace is showing to us. What's happening in the heart beyond just those time frames that we saw on the previous slide. So here's our trace, and you can see at the top it's a 5 millimeter section, and you can see 5 millimeters is about it's about, on this example, about a 1.5 second, sorry, less than about a half a second time frame. So you can see then that has been widened up to what you see at the bottom, and you can see that the trace is now being highlighted, offering a number of different letters, and these letters relate to different responses on the trace, and you can see that they relate to what we call the PQRST wave. And in fact, there is an additional component that isn't shown on there, which isn't always obvious, which is the U wave, and we'll address that as we go through. But you can see the P wave, you can see what's called the QRS complex, because the QRS complex is there's an awful lot going on. It relates to key responses within the ventricles. Then you've got the T wave, and then it repeats. And then with each of those, you've got the PR interval. So that's the interval between the onset of the P wave and the peak of the R. And then you've got the QT interval, which is the time duration between the onset of the Q wave and the completion of the T wave. So all of these responses relate to key activities in the heart. In other words, relate to those time intervals that we're seeing on the previous slide, and therefore must relate to key actions within the heart. In other words, whether the ventricles are being innervated, whether there's a repolarization of the heart, whether it's relaxation, and so on and so forth. So that's what we're going to get into now, to start to understand what these are actually showing us in real time. So here's our signal, and we've color-coded the signal a little bit to make it clearer so you can see different sections. So you can see the P, Q, R, S, and T, and again, we're not showing on this one the U. We'll deal with the U wave later on. The U wave comes as a very, very small rise, pretty much straight after the T wave. So it's not always drawn in a lot of the book-based schematics. So what do each of these refer to? So we'll start off then with obviously the P wave, with this point here, which is just prior to the P wave. So remember the time frame. So we're starting at the sinoatrial node. discharge. There is no deflection. So this is at time point 0, 0. So there is no actual deflection. In other words, there's almost no electrical activity. There is, but it's very, very minimal. But remember, the cycle repeats, and remember this is happening over a very rapid period of time. So now we go into our P wave, and now you can see there's quite a rise, and it's referring to the fact that there is atrial activation. You've got to remember that the left and right atria are being innervated simultaneously, so it's not a case of we do right and left, we do right and left. So we've got innervation across the heart, so you've got right followed by left atrial activation. So that's what your P wave refers to. So we then come into this PR segment, so the gap between the decrease in the P wave and the onset of the QRS complex, and this is in essence what's referred to as the QRS segment, and it's the activation of the AV node and the bundle of His. Remember, we refer to those that occur in about time point 0.4 seconds. So there's very, very little. It will be much, much more bumpy, I suppose, is a technical, not very technical term, but the signal will be a bit more noisy in a real ECG. But as you can see, in comparison to the P wave, it's a fairly flat response that you see for the PR segment. Now we go into this component here, which is the onset of the QRS complex. Okay, so this is where we start coming into the Q wave, and you can see with the Q wave that what happens is that you actually get a decrease in the voltage output before it starts to rise, and this is referred to as septal activation. And if you think about the septum is the part that runs across the middle of the heart. In other words, it creates the boundary between the left and right sides of the heart. And it's really where the majority of the electrical activity or the wave of excitation across the heart is driven from. And so it is not surprising that as we come from this onset of septal activation, we suddenly go into this large component here where we go into the R wave. And we go into the R wave because now there's a big spike in electrical activity. Why? Because we've activated the left ventricle. And think about why that's so important. The left ventricle is fundamental for the delivery of the oxygenated blood to almost all the regions of the body. Not all of them, but almost all the regions of the body. It requires an incredibly forceful contraction. So you're going to get very, very high neural innervation in order to drive that. So high electrical discharge is going to be required to drive that ventricle recruitment. So you get a very high signal in the ECG trace. And it's related to left ventricular free wall activation, so it's the innervation of the wall, so you get the squeezing of the ventricle to shove the blood out from the left ventricle into the regions of the body. And really it's kind of referred to as the inscription of the QRS complex. The QRS complex in essence takes into account what happens at Q, R and S. So now we come into the S wave. So now you've got full ventricle activation. Of course, you think what's happening is that you're now going to drive the contraction. And so we go into that process. We've gone into full systole. So we've had a systolic rise in blood pressure. And of course, at some point, what happens is that you get to that point where we've got to the maximal pressure, the valve closes, and at that point we get the backflow, and the backflow of blood occurs, causing the closing of the valve. And now we're going to go and start to go back down to a diastolic pressure because the pressure has fallen in the ventricle. The pressure goes up in the ventricle as the blood comes in from the atria into the ventricle. As that pressure reaches a high enough magnitude, that's what drives the contraction. As the blood comes out of the ventricle, the pressure now starts to fall, and then we hit diastolic pressure as there's very little blood in. The backflow of the blood, because the pressure isn't high enough to keep forcing the blood out, is what causes the valve, the bicuspid or the tricuspid valve to close, and then the process repeats itself. We then go to the T wave. So now you've got to get ventricular repolarization. So now we've got to get relaxation of the ventricles. And ironically, to get relaxation of the ventricles requires an electrical innervation. It's got to go back to its original length or original state before the process can begin again. And so that's the bundle of His and the Purkinje fibers are what are innervated in order to create this repolarization. And then finally, and this is where you will see a U wave, it's not highlighted on here, it's the final part of ventricular repolarization just before the whole process starts again. And again, it's related to the bundle of His and the Purkinje fibers. So you can see how we've linked the key actions, so that is the activation of the atria and the ventricles, to the key structures of the heart in relation to the change in the electrical activity across the heart throughout a single cardiac cycle. And so you can see how the ECG can be used to identify, if these responses looked abnormal, we'd be able to make good determinations about what's going on at the heart, because we understand how each of these relates to different components of the heart and different time domains of the heart. So here is everything kind of together, and what you can see is the pressures in both the aorta and the ventricle. You can see the ventricular volumes, and you can see the ECG towards the bottom, and you can see how the ECG relates, as we were just referring to, the changes in pressure. So for example, you can see the T wave, where you're getting the repolarization of the ventricles. We've actually got low ventricular pressure because in essence the blood has been ejected from the heart, so the pressure is going to fall. But once we go from the T wave, and of course we've got repolarization, so in other words the ventricle has started to relax, as soon as that starts to occur, blood flows back in from the atria, the pressure is going to rise, as you can see it's doing really pretty much from the completion of the T wave until it reaches a peak at the top of the QRS complex, where we get peak pressure, and that's where you get ejection of the blood from the heart. And so you can see at the top, you can see the responses, so you can see at peak pressure you get ejection, then you get an isovolumetric relaxation, then we get the rapid inflow, and so on. So you can see how here the electrical activity on your ECG is related to the structures and the functioning of the heart in terms of blood flow through the heart. So you can see now why the ECG becomes so fundamentally important to us, because it's making that link between structures, things like AV node, Purkinje fibers, bundle of His, actual mechanics of the heart in terms of contractions, the atria and the ventricles, and the electrical activity that is driving all these processes. So, in order to be able to do this, in order to be able to assess our ECG, we clearly have to be able to record the electrical activity of the heart. And to that end, we have to use ECG leads, and we have to use electrodes. And this is where it gets reasonably complicated, because what ends up happening is people will start referring to what's called 12-lead ECG. Now a 12-lead ECG, ironically, only has 10 electrodes. And you'll see how we can turn 10 into 12. It's like turning water into wine, or turning wood into gold. But actually, it's fairly easy. But there are 3 groups of the electrodes that we put together, and the reason we do this comes back to our understanding of the heart being 3-dimensional. In order for us to create this picture of the heart, we can't have it in one plane. We've got to understand how the electrical activity is being driven across the whole of the heart. So for example, imagine this, my fist was the heart. It's no good just having this frontal plane if actually a lot of the issues is taking place say transversely or to the rear. So this is why we have to create a three-dimensional picture of the heart, and that's achieved by the way in which we place our leads. So the first grouping are what are referred to as the bipolar limb leads. Now interestingly, this is also referred to as Eindhoven's triangle, and you'll see why it's referred to as a triangle in a moment. And these are the ones that I think most people don't think about. Most people think, well, you just must put leads and electrodes across the chest. These are really important ones. So these go on the left arm and the right arm, and they go on the left leg. Now this is really interesting. So here you've got lead 1, 2, and 3. So lead 1 is a positive signal to a negative signal. That's left arm to right arm. Lead 2 is left leg to right arm, so it's positive on the left leg, negative on the right arm. And then the final one is left leg to left arm, which is lead 3. Now the key thing is, can you see how they're changing their angle of view? So what you're seeing is the angle of view, and you'll see this graphically in a moment, the angle of view for left arm to right arm is 0 degrees. It's like that. If you imagine left leg to right arm, the angle of view from the left leg to the right arm is about a 60-degree arc. If you go left leg to left arm, it's about 120 degrees. So let's have a look. So here you can see on the left panel the placement of those limbs. On the right panel, you can see those axis of rotation. Don't worry about the V leads, which are the ones which are the chest leads at the moment. But if you look at AVR and AVL and AVF, which are the primary leads that we're thinking about, because of their placements, they're creating this pattern which sit across here for AVR and AVL. So it's the atrioventricular on the right, atrioventricular on the left, and atrioventricular for the feet or for the left leg. And so what you're doing is creating this picture. And of course, if you think that the arms are sitting slightly back, so they're pulled back slightly compared to the leg, and so now you're starting to build up a map around the heart. But that only gives us 3 of the outcomes. The second are what are referred to as the unipolar leads. So we've had our bipolar, but the unipolar, again, use the arms and the leg. So now we're going left arm positive terminal. So this is just the left arm. So this isn't connecting, this is just going on the left arm. So this is the positive terminal, that's referred to as AVL. And that gives us about a minus 30-degree angle compared to the heart. The right arm to the positive terminal is the AVR, gives us about a minus 150-degree angle to the heart. Remember where the heart sits in relation to the right arm. And then the left foot, just to the positive terminal. When we say the positive terminal, that is remember, we've got to measure both positive and negative, that's polarization and repolarization of the heart. So we've got electrodes that are designed to pick up positive signals and negative signals. The unipolar leads are designed to pick up just the positive signals, whereas the bipolar leads create, in essence, a network. Can you see that we're going positive to negative, positive to negative, positive to negative? So they're creating a network, whereas the unipolar leads are only interested in the positive discharge. And you can see that we're going from minus 150 degrees to about a 90-degree angle, depending upon the electrodes that we place. So they're our first grouping. So we've got our main leads. The final set then are the ones that most people will think about, which is the unipolar or pericardial leads. So now we've got leads V1 to V2, and they look at the activity across the right ventricle. V3 to V4 we call the intraventricular septal activity, and V5 to V6 we call the left ventricular activity. So you start to look at this and you think, okay, there's all my leads. So you can see the Eindhoven's triangle, and you can also see the V leads. And what you'll do is you'll count those up and you'll go, oh crikey, there are only 10 electrodes. There are only 10 electrodes, but what you've got is you've got 12 leads. That is, you've got 12 configurations using the 10 leads. Remember that we're using some of these leads twice. Okay, left arm, right arm, and left foot. So we've got multiple uses of those. The net result is that it's 12 leads using 10 electrodes. And now what we have is this three-dimensional excuse me, this three-dimensional representation of what is going on in the heart using the electrical activity. The left-hand panel shows you quite clearly the positive and the negative charges for the particularly for our unipolar and our bipolar leads. The unipolar pericardial leads are in essence just recording the activity at the heart. They're not creating an electrical almost circuit. So here we can see a little bit more detail, and you can start to see the placement. Now this is something that we're going to come back to towards the end of this podcast, which relates to really this kind of necessity to be able to get these leads placed correctly. And you can see V1, you can see V2, V3, V4, V5, V6. So you can see all those placed. You can see RA and LA, and you can see them all placed quite neatly. But one could understand that they are having to be placed in particular locations because we're trying to build up this picture of the heart. And if we get those electrodes out of alignment, then one would think that you would change the way in which you view the electrical activity of the heart. So lead placement is absolutely fundamental, electrode placement is fundamental to generating a really suitable ECG trace.